So when do I decide to refer for ablation or to use antiarrhythmic medications? So this is the newest European Society of Cardiology diagram looking at when you use which antiarrhythmic medication when you refer for ablation. So I like to kind of divide groups of patients up into patients with underlying heart disease and patients with no or minimal heart disease. So if you have heart failure, you actually break them up into New York Heart Association Class 3 or 4 or stable New York Heart Association Class 3. If they're stable, we can use dronedarone or Multac. You know, there's a black box warning now saying that if a patient has had recent symptoms of heart failure or Class 3 or 4 unstable heart failure, you cannot use Multac because it increases mortality in those patients. So in those patients, really your only option is amiodarone, and sometimes you can also use sotalol. In Europe, they don't use sotalol as much, but in the States, we do use sotalol in patients with heart failure. It can worsen heart failure at times just because it's a beta blocker. Stable heart failure, you can use dronedarone. Patients with coronary disease, you can't use the 1Cs like flecainide or Rhythmol, but you can use dronedarone and sotalol. So these are all first-line options. So hypertension with LVH, again, you can't use 1Cs such as flecainide and Rhythmol, but you can use dronedarone or amiodarone as a last line of therapy. And catheter ablation in those patients is usually second-line therapy. So patients with some sort of structural heart disease, we generally do try an antiarrhythmic drug. We're a very high-volume center, so we're a little bit more comfortable offering patients ablation at a little bit earlier stage. So generally what I'll do is if they can't take, we'll try them on dronedarone if they have LVH or stable New York Heart Association Class 3 heart failure. Or if they can take a Class 1 antiarrhythmic such as flecainide or Rhythmol, we'll always offer them that first because that's an easy outpatient therapy. They can take it at home, they don't have to be in the hospital. Once we move on to therapies such as sotalol or Ticacin, where they have to be in the hospital often to initiate the medication, we say, well, you know, you can be in the hospital 3 days and be on, you know, one of these medications, these Class 3 antiarrhythmic medications, or the other option is to undergo an ablation. So that's the point at which I generally offer an ablation. When it comes down to amiodarone, if the patient's younger, I call young under the age of 75, this is probably not the best drug because after 2 to 3 years, probably about a third to 40% of patients aren't able to tolerate amiodarone long term just because of eye toxicity, liver toxicity, lung toxicity, thyroid toxicity, and skin toxicity. So obviously amiodarone is a great drug. It's a very strong drug and is good at maintaining sinus rhythm, but long term it's not the best drug for most patients that you think are going to survive a significant amount of time. When you look at patients without heart disease, paroxysmal atrial fibrillation, there's actually a pretty good level of evidence that catheter ablation can be first-line therapy. And there's actually just a trial that looked at this, and they found that as far as side effects are concerned and adverse events, catheter ablation actually has significantly less side effects at 1 year than medical therapy. It was something on the level of around 16 or 17% for medical therapy and about 6% for catheter ablation. So it was statistically significantly better than medical therapy, and that was generally in the paroxysmal AFib arm because they have generally the best results, and we'll get to that. For persistent atrial fibrillation with no heart disease, we generally do try one of these medications and try to get them back in sinus rhythm, make sure they feel well in normal rhythm, and then consider an ablation after one of those therapies fail.